All right. This evening I will be discussing pediatrics. Um, my name is Megan. I've picked pediatrics as my topic for this final project because I feel like pediatrics is almost a subject that goes hand in hand with applied behavior analysis and is something that is kind of near and dear to everybody's hearts, as it is typically the community that most of us are working in when we are in the field of ABA. A lot of us work with small little children, so it's helpful to understand how pediatrics or how the community of pediatric medicine can go hand in hand with the ABA and how it can assist us with creating our own interventions. So what is pediatrics? The American Academy of Pediatrics has come up with their own extensive definition, being that it is a specialty of medical science concerned with the physical, mental, and social health of children from birth to young adulthood. Pediatric care encompasses a broad spectrum of health services ranging from preventative health care to the diagnosis and treatment of acute and chronic diseases. It is a discipline that deals with biological, social, and environmental influences on the developing child and with the impact of disease and dysfunction on development. Children differ from adults anatomically, physiologically, immunologically, physiologically, developmentally, and metabolically. So, what does this mean for us? In our field as board certified behavior analysts or as students working towards earning that credential, we learn that our field focuses on those similar concepts. We work to make socially significant changes that will improve our clients' day-to-day lives by looking at biological, social, and environmental influences that could impact their development. We look at all sorts of medical variables when creating our interventions, similar to what the American Academy of Pediatrics is suggesting within their definition. So I think three of the biggest topics that I've encountered within the subject of pediatrics and while working in the field of ABA are as followed: pediatric feeding issues, toilet training, sleep disturbances. In the field of ABA, most clinicians run into these topics as problem areas for their clients. All three of these topics have the potential to ebb and flow and affect one another as well as other abilities, such as if you don't eat well or in general don't take in enough nutrition, this could affect your toileting. If a client is up all night because of constipation or bedwetting, this will obviously affect their mood the next day and how much sleep they're going to get. It's also just going to affect their overall performance. Each of these topics has a potential to relate to one another or contribute to a different factor as to why there could be disturbances in one of these fields. From here on out, we'll be discussing a few studies that have researched some solutions and interventions on each of these topics and within the field of ABA. So first, we'll start off with pediatric feeding issues. Parents often identify three potential areas they struggle with when it comes to pediatric feeding. Oftentimes they find that their child is super selective about foods they might eat. You could hear complaints about, oh my gosh, he'll only eat mac and cheese for dinner, or maybe they'll only want fruit snacks. It could be feeding related medical issues, such as they find parents notice that when their kids eat specific foods, they get an upset stomach. So they switch their diet around, trying to determine what common denominators might be affecting their stomach. Like, are they getting too much gluten, dairy, sugar? Like maybe switching things around, trying to find something to pinpoint exactly what it is that's disturbing their child's medical diet. Or they're just point blank refusing food altogether. They don't appear to be interested in food. They gag whenever food is presented to them, and therefore they're not consuming enough food to help meet their daily caloric intake. Nutrition is something that's very important for our kids. So when our kids are refusing their foods, parents obviously get very, very concerned. In a study by Suebert et al., they implemented and evaluated the effects of different antecedents, such as using pacifiers and spoon flipping that could be implemented during feeding procedures with parents that was combined with escape extinction to kind of help pinpoint which of the three areas their child was leaning towards. They defined food selectivity as select foods from a certain group or with textures, tastes. So maybe the kid doesn't like soft textured foods, or they don't like something crunchy, it hurts their teeth. They defined feeding-related medical issues as use of or history of using a feeding tube or some form of digestive disorder, meaning they have some sort of history of a gastrointestinal issue. And then they defined food refusal as did not receive enough calories in one day, either due to one or a combination of two feeding dependence or 90% liquid calories or just poor oral intake, meaning that they point blank are refusing the food, or they are mostly surviving on a liquid diet or liquid calories such as juice, or I think a common one is Pedialyte. That's one I see often at my clinic. In assistance with this, they combined those definitions and they utilized pacifiers and a spoon flipping technique. And the pacifiers were used to kind of prep the child's mouth so that it was more receptive to the food bite that was being presented to them. And then spoon flipping was used in escape extinction, as in if the child accepted a bite and then held the utensil in their mouth for too long, the parent would come and manually flip the utensil as if almost kind of like dump the food, so to speak, onto their tongue and kind of encourage them further to take the bite. They also used chin prompts, so they would kind of hold the child's chin to help steady them if they were shaking while taking the bite. And then chasers were also provided, so if the child was eating something that seemed to be a texture that didn't agree with them, or a taste profile that was new, or something they didn't seem to like, they were provided with a chaser, a preferred food or drink to come immediately after that undesirable bite to kind of help them swallow and like learn to take that swallowing that bite. Or they even went as far as to blend together the unpreferred or new foods with a blend of their actual preferred foods to either disguise the food itself or to just kind of give it a more familiar smell, taste, texture, just to make it a little bit more enticing to help them expand their palate. It's important to note that they did extensive prep to identify any feeding related medical issues. Why would that be important for us to know? It's important for us to know because we have our ethical code that says that we are held to recommending other treatments or interventions if there is an alternative solution that is medically related. So if a kid is experiencing something that might be medical or biological, that's obviously outside of our wheelhouse, and we should recommend them to seek out a doctor or some sort of other professional that is more inclined to that, so that we're not recommending a solution that isn't compatible with what's going on, such as medication for a gastrointestinal issue. We can't prescribe medication. So with that, we have toilet training. Similarly to feeding, pediatric toilet training is another topic in which BCBAs can and most likely will encounter with their clients, because toilet training is so intensive and it takes a lot of preparedness. Adhering to Code 4.02 involving our clients in planning and consent is extremely important, as it involves spending a good amount of time in the client's personal space and often home when teaching them to void on the toilet. It's a very personal time for them. We are in their homes, we're in their environment, we are where they are most comfortable. It's really important to remember to respect their dignity and respect that this is their natural environment and that we are there to help make them more independent in their life. If toilet training is not successfully completed on their own, other side effects from lack of toilet training can be seen, such as increased bedwetting or an off-kilter sleep schedule. There could be negative associations with the bathroom, so some kids might even refuse to go on the toilet altogether just because they have negative thoughts about it. And then it can also lead to a stressful home environment. Parents with children with developmental disabilities report having a higher personal stress and or distress when thinking about or attempting to toilet train their child. So Kroger and Sorensen conducted a study with 2 children. One of them was named Marvin and the other one was 6. They were both small toddlers. Marvin was 4 and Chris was 6. They did a replication of the Azrin and Fox study, and they implemented those 5 techniques as in they increased the fluid. So both boys were given an increased amount of fluid, so they were drinking fluids constantly, whether it be water, juice, anything that was preferred, just to really increase the amount of fluids they were intaking. they were scheduled to sit on the toilet. So they would increase the amount of time they spent on the toilet between voids or to get stretch breaks, meaning that they could start off with an interval of 10 minutes, and after 10 minutes, if they haven't gone to the bathroom, they could get up and stretch, and then they went right back on the toilet, and they stayed there until they did their complete void. And then in between voids as they were going, their break time and stretch time off the toilet could increase as well. They used positive and negative reinforcements for the target behavior, i.e. the in-toilet voids. So whenever the child voided on the toilet, they would get their desired candy reinforcers and verbal praise for voiding on the toilet, being told what a great job they did doing on the toilet, whereas not voiding on the toilet resulted in being redirected or having if they had an accident, they were returned immediately to the toilet, and they weren't allowed to leave the toilet until they successfully voided on the toilet. And then after that, there would be scheduled sittings on a chair next to the toilet to help increase the amount of self-initiation that Chris and Marvin were having. So they'd sit next to the toilet on their chair in hopes to increase the amount of them identifying within their own private events that they had to go to the bathroom, and then being able to say, I have to go to the bathroom, and seeking out the toilet. And here are their results. So it's the percentage of daily accidents and self-initiation for both boys. So you can tell in their study how they were starting off with more accidents than successes or self-initiations. But by the end of the study, both boys were had definitely increased the amount of self-initiations that they were doing. Or I should say Chris was increasing the amount of self-initiations he was doing. Marvin's were a little more variable, but by the time he reached the follow-up stage, he was also self-initiating quite well. The results of this study found that the procedure itself was effective in teaching the parents the toilet training procedures, and it contributes to the growing amount of research supporting this methodology, as it can improve a client's independence, and it is a skill that can be generalized across many environments. So if a kid's learning to go to the bathroom at home, the chances of them generalizing that skill to grandma's house or school are quite well. This study did a really nice job also as showing how well the parents did, as Kruger and Sorensen gave the parents the training themselves and had the parents implement the study and self-report what they were doing with the study. With toilet training, there comes a lot of benefits. It's improved independence, reduced stress for the parents, and then it's a generalized skill across multiple settings. It also can lead to a lot of other great things. So if toilet training was something that was causing with your sleep disturbances, being able to hone in that skill itself and will help with their sleep patterns in the future. So lack of sleep can be attributed to feeding issues, illness, difficulty initiating sleep at nighttime, meaning that the child often will have a difficult time laying down and just naturally self-soothing themselves to sleep. I know I have nights where I hit the pillow and I'm out like a light and nothing can wake me up. For a lot of our clients, that isn't the case. They lay there in bed and they can't fall asleep, which then leads them to lay awake at night, and then will obviously affect their performance the next day. Sleep disturbances can often be attributed to biological variables that can tie into pediatric feeding problems as well. The study that for this section by Reed et al. Specifically investigated how feeding issues can be related to irregular sleep patterns, and by causing those irregular sleep patterns, it brought out a lot of new behaviors due to the child not being able to get the sleep. They did find a correlation in the end that found that the lack of sleep the client got resulted in them refusing food the next day specifically. In his graph, they implemented a DRA plus escape extinction, meaning that when they were working on feeding procedures the next day after he had a poor night of sleep, they would reinforce his alternative behaviors, whether it was him saying that he needed a break from food or took the bite willingly. The percentage of bites accepted during the meals that were sleep disrupted are the open circles, and the not sleep disrupted are the filled circles. Their results concluded that sleep can alter and or can alter the value and or effectiveness of reinforcers when attempting to work on other behaviors during the day. So they noticed that when he didn't have a good night's sleep the next day, when they were trying to work on his feeding issues, they had a poor time at it just because his attention wasn't there. He would become aggressive, and it really affected the value of his reinforcers because he was just so exhausted that food wasn't motivating for him and he didn't want to work for it. So, in the wide world of pediatrics, why and how does this affect us as behavior analysts, or in my case, a student of ABA? How could pediatrics possibly be used with our field in general? I mentioned earlier that pediatrics kind of goes hand in hand with the field of ABA, just because the majority of us tend to work with smaller kids. So within the field of ABA, we have our 7 principles: generality, effective, technological, analytic, conceptually, systematic, applied, and behavioral. And what those basically are asking us is, how are our interventions, how are our procedures geared towards our client to make their life more socially significant? How can we improve their day-to-day living capabilities? So with sleep disturbances, with feeding disturbances, with toilet training, those skills are general. They can last a lifetime. Teaching skills like productive eating habits and toilet training can be applied to multiple environments. So if we're learning something in the home, or even a center-based clinic, when we're going to school or we're going to a relative's house, hopefully those skills transfer over and we're able to execute those skills in multiple environments. Our skills effective. The pediatric world is very effective. We're using practical applications to make practical change. So our effective intervention, we're trying to create effective interventions to replace undesirable behaviors, i.e. bedwetting. So when we're looking at our interventions for bedwetting and we're looking at the pediatrics roles of bedwetting, how can we combine the two of those to help our kid have a nice sound sleep at night instead of waking up in a puddle? Are they technological? So for us, that means that they're described in a way that's easily understood and in a way that it can be replicated. So are we writing our results in a way that our parents can implement them at home? We saw that with the toilet training scenario, when the parents were able to successfully implement their toilet training procedure with their kid at home without the assistance of the BCBA at their home every single day. Are they analytics? So are we identifying a functional relationship between the behavior and environment? Or how are we identifying how negative reinforcement during dinner time can create undesirable eating habits? Is it conceptually systematic? So are we using ABA terminology? I think it's really important that we collaborate with other fields, whether it be pediatrics or occupational therapists or speech therapists or even sports medicine. Any field that we're collaborating with, are we able to take what studies they are providing, what research they are providing it, and turn it into, or convert it with ABA terminology so that we are able to present it in a way that is applied and behavioral. So in that way, are the behaviors socially significant to the client? So the interventions, again, are supposed to be something that's supposed to better their everyday life. So when we're toilet training, we're hoping that they're able to have more skills that are important to them. We're hoping that when we are sleep training them, that they're able to have an effective night's sleep so that when they wake up in the morning, they're refreshed and they're ready to be as productive as they possibly want. And we're hoping that by helping them get over whatever eating habits they have, that we're able to give them a better quality of nutrition and that we're able to give them more fuel to get them through their day. And then last but not least, is it behavioral? So is what we're intervening on objective and measurable? I think a lot of things that pediatric doctors look at, whether it be toilet training or feeding, those are objective measurable goals. So we take that and we look at it and we have an objective measurable number of how many accidents at night are they having? How many bites of food are they refusing? How many accidents like at school are they having? Just having that specific number and looking at our baseline data to determine where to go from there instead of just blindly picking an intervention and hoping that it works. So with our 7 dimensions of behavior analysis, We also have our ethical code that we have to adhere by, and I've mentioned some of them throughout the PowerPoint, but medical consultation. So are we recommending that they seek medical consultation if it's needed? So if something is medical or biological, we are not licensed to make any recommendations based off that, and we should be collaborating with a pediatrician so that our client is getting the best possible care that they can have. Are we involving them in the planning and consent? So a lot of things like toiletrating or feeding, those are very like personal, very invasive procedures. So like if we're trying to have our kid learn how to swallow a bite that is just very painful for them, that's a very powerful private moment for them. And are we respecting their dignity? Are we involving mom and dad in the planning and consent? Are we talking to the client? Are we getting their consent about what foods we're trying to expand their palate on? And then are the behavior change programs, are they individualized? Are we looking at our client specifically and saying this program was tailored for you? It was tailored towards your environmental intervention, your environmental variables, and we are looking at your baseline data to create your intervention. Based off of those 3 specific ethical codes, there's obviously many, many more. We have the different task list things that as ABA students we could possibly look at. So are we creating intervention based on the manipulation of antecedents? So we have so are we trying to modify your environment so that the client isn't engaging in the behavior? Are we able to define a behavior in an observable and measurable way? So like, are we able to create a measurable definition for the behavior so that if we gave that definition out to parents or other caregivers, they would be able to know what it is exactly we're measuring? And then are we considering biological and medical variables that might be affecting the client? Again, we're not doctors. We can't prescribe medicine. There's only so many different assessments that we can do. We should be fighting to collaborate with other professions if it means giving our client the best, most independent life possible. And then when we're defining our behavior in observable and measurable terms, are we also defining the environmental variables that can be observable and measurable? Like, are we identifying what variables could be affecting them the most? And then from that all, are we creating an individualized assessment that can help us create the best, most possible game plan, something that can be translated from our clinic to home, to school, to relatives, just something to give them the most best possible life. So what is next? Additional resources that we can have. I think collaborating with other disciplines is a really big thing, as you can learn a lot of tips and trades from them. I know I myself have learned a lot of great feeding techniques from different speech pathologists over the years that my BCBAs that I've studied with have collaborated with. So for sleep disturbances, the American Association of Social Workers, they have educational online modules that or sleep care education modules online that they offer to parents, or even BCBAs could take, or students could take if they just want more information about different sleep training programs that aren't necessarily geared towards research. That's just more of, or I shouldn't say that, they're research-based. It's more of modules that kind of help give them a brief overview of different sleep training interventions they could attempt to perform on their own. For pediatric therapy, or for pediatric feeding, the Association for Speech and Hearing, they offer different techniques for different swallowing and feeding guidelines, and then as well as offering different tips for toilet training if you don't want to do something as intensive as Azrin and Fox's study. And with that, I have concluded. I think future research should look at how to collaborate, or I think ABA research should focus more, or not should focus more, but I would be interested in seeing more research in the field that combined and collaborated with multiple disciplines across different, and creating their own combined solutions for different issues that parents might be facing, whether it be feeding or toilet training or sleep training.